All right, everybody, welcome back to the Medical Biochemical Genetics Clinical Course Seminar Series. It's October 27th, 2023. This is week 15 of the series, and we welcome Dr. Oleg Shchelochkov from the NIH to talk more about organic acidemias. Just as a quick reminder, we'll have the CME information in the chat, so you can register if you'd like. You can also evaluate the course and the lecture. And next week, this is an important announcement. Next week, because of ASHG, Dr. Sutton, Reed Sutton from Baylor, is going to be talking, but because of a conflict, he's going to have to do it an hour later. So we're going to be starting at 1 o'clock Mountain Time, noon Pacific, 3 o'clock Eastern. For anybody who is paying attention, it should already be moved on your calendar. So stay tuned for that. Hopefully, we'll have people joining at the right time and not too early. I'll try to probably get on around noon and redirect people for anybody who hasn't heard this. So with all that, Dr. Shchelochkov, I'll leave it to you.
Okay, well, thank you so much again for joining us. I hope everyone can hear me okay. Once in a while, I do have some audio issues. Just post your you can post your comments in the chat, and I'll be keeping an eye on them here on one of my side monitors. So today we'll be covering the second part of organic acidemias. I believe that Dr. Manoli already presented her part one, and she covered methylmalonic acidemia quite extensively. You may see quite a few parallels between propionic acidemia that we'll be discussing today and methylmalonic acidemia. But I noticed that the longer I do this, seeing patients with organic acidemias, the more different some of these conditions and even some sort of strata within each conditions become. I have no disclosures. And today's learning objectives is number one, to understand the mechanisms and the biochemical map that underpins these conditions. The second thing is formulate and understand the different diagnostic approaches that we use to identify these disorders in clinical practice, and discuss and define common management strategies, those which most people would consider mainstream and those which are somewhat controversial. So we can talk a little more about different approaches that we've seen and documented as we see patients. If it's okay with everyone, I would like to just get a better sense for the audience. If you could post in the chat anonymously your role, whether you are a nurse practitioner or genetic counselor or a trainee or a physician, and where you're coming from. If you could post that in the chat, that would be really great. And I'll be keeping an eye on it. Again, that will help me to understand a little better and customize some of my discussion about different newborn screen strategies and treatment strategies. Right, I see Canada, East Coast, Midwest, West Coast. All right, thank you very much. I really appreciate it. We'll give everyone maybe one more minute to post your comments. It looks like most of our people are here from the US and Canada. I hope I didn't miss anyone. Okay, well, I'm going to move on. We'll keep adding your comments in the chat. For the warm-up, I would like to offer three questions, which are kind of highlighting different aspects of organic acidemia. So question number one, you are encountering a newborn who presents with lethargy within the first 24 hours of life. And her electrolytes are sodium 135, potassium 5 chloride 100, bicarb 10. When I see something like this, I always do this math in my mind to calculate anion gap, which is 20 in this case. Glucose is low normal. Ammonia level is mildly elevated. At the same time, while you're doing examination, evaluation, and reviewing labs in the NICU, you're getting a phone call from your newborn screen state program, which suggests that one of these five conditions is probably on the list. Which of these is most likely being reported? So if you could post your answer in the chat. It's not supposed to be a trick question. It's just again as a warm up. Thank you very much. I can see some answers coming in. Yes, it is correct. Answer A is the most likely diagnosis to be reported by the newborn screen program. Elevated C3, most likely PA, and methylmalonic acidemia. This particular combination of laboratory findings is referred to as HAGMA sometimes, high anion gap methylmalonic acidosis. And in humans, there are actually not a lot of biochemical compounds that can be produced in sufficient quantities and have sufficient relatively low and can shift the pH to manifest to present clinically and biochemically. And I'm listing them here. These would be the most common: lactate ketones, methylmalonic acid, and pyroglutamic acid. So this is, again, when you think about high anion gap methylmalonic acidosis, think about these four chemicals, and also look for elevated ammonia. And when you see a combination of this, it's very likely to be an organic acidemia, and I would say more specifically, methylmalonic acidemia. Interestingly enough, actually, again, you may see significant metabolic acidosis in PA, but I don't think it is as those numbers are as profound as what we've seen and documented in methylmalonic acidemia. The next one is a question about a newborn screen that is positive for elevated C5OH or C5 hydroxy. What is the most likely diagnosis? This is a little bit of a trick question because as you look at these answers, you can probably get a sense that many of them could be correct. And so they need to have need to know a second piece of information, the prevalence of the condition. So if you could post your answer in the chat. Well, I'm dealing with a very sophisticated audience. Thank you very much. That is correct. Answer B is the most likely. Again, all of them can produce or present with elevated C5 hydroxy, but based on the disease prevalence in North America, it's most likely to be 3-MCC deficiency. We're going to talk about this a little bit later. And my last question is about an infant with hypotonia, a 4-month-old infant admitted to your hospital with failure to thrive, hypotonia, seizures, thin and sparse hair. You also notice eczema, which mom and dad report has been resistant to treatment with topical creams. And this is this infant's first visit, 4 months of age. The family is migrant, and you have access to genetic services at your hospital. A biochemical geneticist ordered a urine organic acid assay, which revealed several biochemical. Yes. Thank you very much. The answer is D. And I suspect that the clue here is that you see that several parts of the biochemical map are affected, suggesting that we're talking about one element that affects multiple enzymes, and multiple carboxylase deficiency, of course, is going to be the most likely answer here. Well, thank you very much for your answers. Again, I'm very glad to see that you are able to keep up with these questions. Organic acidemia. So we're talking about a very large group of conditions, but today we'll be focusing specifically on PA, IVA, multiple carboxylate deficiency, 3-MCC deficiency. Most of these conditions are caused by defects in enzymes which participate in oxidation of branched chain amino acids or lysine. As a group, it's actually very common when you put them all together, especially given the newborn screen programs that are well established in most countries. These conditions collectively can be seen in as many as 1 in 5,000 to 20,000 newborns. Clinical manifestations are very diverse. And not just that the manifestations are diverse, but even similar manifestations can be very diverse in their severity, which I think is what makes it so difficult to identify them clinically alone. So without a prospective screening, it would be really easy to miss them. And outcomes, I would say for most of these conditions are guarded, but we do have quite a few examples in this group of conditions we'll be talking about today, which have relatively good outcome or excellent outcome with treatment. So the key thing is to identify them as early as possible and start appropriate treatment. So this is a quick summary of of what I just described, the oxidation of leucine, isoleucine, and valine. As you can see, there are several biochemical steps. They are somewhat overlapping. In what I mean by that is that, there are some of the biochemical steps here that are shared, like the first two steps in the oxidation of branch chain amino acids are performed by the same enzyme. So there's some the substrate specificity is not too high, but as carbon or organic acids move through these different pathways, the most common chemical reaction that happens to them is dehydrogenation or oxidation. Eventually, in the end of this pathway, they all converge together, either in the form of acetyl coenzyme A or in the form of succinyl coenzyme A, which enter Krebs cycle, and that's where they complete their oxidation. Of all of these conditions, as you can see, there are many different enzymes represented on this biochemical map we'll be talking about. Let me switch my pointer to this. So we'll be talking about this condition, 3-MCC, and you can see the two stars. I guess just my way of saying that we'll be talking about multiple carboxylase deficiency, which can affect both of these carboxylases. I think it's been one of the hallmarks of dealing with patients affected by these conditions is that they, on the more severe end, they are really very difficult to manage. And I think this is in part happens for two reasons. Number one, the first step in these pathways is reversible because it's transamination, and depending on the substrate and nutrient availability, they can go in either direction. But the second step here, and that's the oxidation of the oxidative decarboxylation that happens here, is irreversible. In other words, once these organic acids enter the pathways past this enzymatic step, it is committed and they have to go through the rest of the biochemical steps. And if any of the enzymes are in this pathway are deficient, then it is going to lead to the accumulation of organic acids, which are, due to the nature of, of these compounds, are going to cause metabolic acidosis. Now, this pathway resides in the mitochondria, and that's why I think as we talk about the clinical and biochemical and laboratory manifestations of these disorders, you will see that there's quite a bit of overlap with primary mitochondrial disorders. So that's one of the reasons. So I guess, it's the irreversible nature of this biochemical pathway. Number two, it's the location intracellularly where these enzymes reside, causing mitochondrial dysfunction. That's why we deal more often than not with very severe manifestations. But the third thing is isoleucine, valine, and leucine are essential amino acids. And therefore, while it kind of makes sense that restriction of these amino acids should decrease the manifestation and accumulation of organic acids in these pathways, you can restrict these amino acids only so much because you have to provide enough for isoleucine, valine, and leucine for normal physiological growth and development. And even if you are able to perfectly calculate your dietary prescription, there's still an endogenous source of these amino acids, which sometimes gets activated due to catabolic catabolism, under physiological stress, trauma, under fever, infections, and that's why even if you calculate your dietary prescription, to control the endogenous pool of these amino acids can be challenging. That's why in practice, it's not one of the easiest things that we do in clinic. Now, we talked a little bit about prospective identification of this condition as the most important step and probably the biggest shift in the paradigm for this condition. And it has become an essential and critical element in identifying these patients and starting therapies early. I'm not going to dwell on the nature of the newborn screen results, but maybe highlight only one, and probably the most important thing is that although we're talking about organic acids, it's usually not the organic acids that we identify on the newborn screen. We usually find carnitine conjugates of these compounds, and therefore you will see essentially elements of acyl carnitine profile on the newborn screen results, plus changes in amino acids. We'll talk about which amino acids you should be paying attention to on this test a little later. The newborn screen is an evolving field, as you probably know. A lot of these conditions have been part of the core group of disorders, but newborn screen obviously continues to add new conditions. But the core and the secondary targets seem to be have not changed too much over the last many years. So, and as you can see, propionic acid, isovaleric acid, 3-MCC is part of the core conditions. So it is really important to become familiar with the both manifestations and biochemical signs of it. I really like this paper by our colleagues that are listed here, which I find very helpful as a first step to familiarize with different, acyl-carnitines that we deal and are relevant for this talk. And I'm just going to highlight here by putting them in red boxes, some of them which are relevant for our conversation today. Number one is the elevated C3. Just to be sure, the nomenclature, when you see C with the number next to it, it refers to the number of carbons in that molecule that is attached to carnitine. Just to give you some idea about the nomenclature. If you see OH, that means there's a hydroxy group that is present in the in that molecule. So elevated C3, also referred to as propionyl carnitine, can be elevated in several conditions, including propionic acidemia, methylmalonic acidemia. But unfortunately, and I think as many of us know, you get a lot of phone calls about abnormal newborn screens coming from the NICU, and that happens due to prematurity, in part probably because of the liver immaturity, sometimes renal dysfunction, and sometimes it can be the combination of excess nutrients that these infants receive through parenteral nutrition and so on. Rarely, but it does happen. This C3 can be elevated as a result of maternal B12 deficiency and be picked up because the transit, B12 deficiency in the infant. Other compounds that are of value here is elevated C5 that can be elevated in isovaleric acidemia. That's a product of the leucine metabolism, impaired leucine metabolism, and then 2-methylbutyryl coenzyme dehydrogenase that sits in the isoleucine catabolic pathway. Again, the reason why you see two compounds here, isovaleric acid and 2-methylbutyryl coenzyme A, is because both of them have 5 carbons, but when you have 5 carbons, you can arrange them in 2 different ways. One of them is a linear form, and the other one has a branch structure, like 2-methylbutyryl coenzyme A. So that's why you will have the same molecular mass, and depending on your specific methodology, the methodology may not be able to resolve these 2 different structures completely. So that's why you may see overlapping peaks there. C5OH can be elevated in 3-methylchlorodynyl coenzymic carboxylase. There are cases of maternal 3-MCC deficiencies that have been identified through the newborn screen based on the positive newborn screen in the infant, and biotinidase deficiency, and we'll talk about that a little bit later. And then when you see multiple peaks identified, if they can form different patterns. For today's talk, the elevation of C5-1, C3, C5-OH can be seen in multiple carboxylase deficiency, which combines full carboxylase synthase deficiency and biotinidase deficiency. Again, we'll talk about them a little bit later. Organic acidemias affect multiple systems, and I'm just listing them here for your convenience to make sure that we we will cover most of the systems in the subsequent slides. But even though their symptoms will be overlapping, you will see that the prevalence of these complications can be different. For example, in patients with propionic acidemia, cardiomyopathy tend to be one of the complications that is rarely seen in methylmalonic acidemia. Or chronic kidney disease tends to be seen with more frequency and earlier in methylmalonic acidemia, but it's seen less at a much later age in propionic acidemia. It can be just as severe, by the way. Some patients do have to receive kidney transplants, but it tends to be a later complication. Other complications which are very common among many organic acidemias is acute and chronic pancreatitis. And chronic encephalopathy, and sometimes basal ganglia strokes. Now, basal ganglia strokes tend to be seen or associated with more severe forms of these conditions, and are in like multiple carboxylase deficiency. You rarely see those complications if patients receive treatment in time and sufficient doses. Propionic acidemia will probably consume most of our, will consume a lot of our time today, in part because this is probably one of the more severe examples of an organic acidemia, so there are a lot of things to cover. Also, there are some controversial topics that we'd like to introduce to you, and at least help you formulate your thoughts and opinions about what to do when you encounter a clinical situation in that context. Well, taking a step back, looking at the pathway, the most common sources of protein coenzyme A and propionic acid in the body is isoleucine valine. These are two of three branching amino acids. Methionine and threonine, as you notice, all four of them are essential amino acids, which is why it's very difficult to manage it by protein restriction alone. So you have to really calculate the intake really well, adjust it to a patient's development and linear growth, and then also adjust it depending on their clinical situation. The other big source of propionic acid is gut-derived propionate, that we have a lot of bacteria in a healthy gut that are propionate fermenters. And under most conditions, it's a really valuable source of energy in an otherwise healthy individual. But in patients with propionic acidemia, excess propionate production coming from gut can overwhelm their metabolic block. I also wanted to highlight maybe one more thing that I think is of value. Not all these four amino acids are equally contributing to the formation of propionic coenzyme A. I think Jerry Vockley and his group have shown it very nicely that probably isoleucine is a much larger contributor of propionic coenzyme A as opposed to methionine, threonine, valine, which I think can give us some ideas about, as we continue to develop our therapies, whether we should, which of these amino acids we really need to restrict and which of them we can be a little more lenient in terms of their intake. Excess of propionic coenzyme A at the step propionic coenzyme carboxylase will lead to formation of secondary or propionate-related compounds. I listed three of them, which are most helpful for diagnostic purposes: 3-hydroxypropionate in urine, 2-methylcitrate, typically in urine. You can also detect them in blood, of course, and propionylcarnitine or C3 that you will identify on the nasal carnitine profile. The elevation of C3 is a relatively common phenomena. You will see a lot of these in a regular hospital. You will see a lot of them coming from NICU, and this is probably one of the more common analytes which are being called out by the newborn screen programs. Follow-up or second-tier testing will show massive elevations of 2-methyl citrate, but also pay attention that there's no methylmalonic acid, elevation of methylmalonic acid. So this is an important positive, 2-methyl citrate, and the pertinent negative, absence of methylmalonic acid. Because if you see elevations of both of them, that's probably is going to be most likely caused by methylmalonic acidemia. These days, I think all of us will commit to confirmatory testing using molecular methods. Rarely these days I see enzymatic assays like multiple carboxylate testing. I see it once in a while, but rarely so. And interestingly enough, and in PA, I would say that we had been able to confirm PA as diagnosis on the molecular testing by sequencing PCCA and PCCB in practically every single case. So it's really good to it's a really good test in this setting. So I think C3 is one of those metabolites that can keep you very busy if you interface with the newborn screen program. In part because there will be many calls coming from the NICU and premature infants where C3 can be an isolated finding. That's why you will see secondary markers such as C3, C2 ratio, C3 to C16 ratios as a way to isolate or stratify these cases. When you see elevation of both C3 and secondary markers, it's more likely to be a real thing. Now, keep in mind that there are some states in the United States, and I don't really know about newborn screen programs in Canada. Please feel free to add your comments here, where C3, C2 ratio can be treated as a primary marker. So there are some newborn screening programs which do that. So in other words, can be C3 can be just under the threshold, but C3 to C2 can exceed, let's say, a ratio of 0.22. So that I've seen that as well. When you identify it, I would definitely personally would move on to the second tier testing when you see elevation of C3, C2, and C3 to C2 ratio. I would recommend, and this is what I do, and I suspect that most people will do the same thing, is they will order urine organic assay, plasma acyl carnitine profile, totally free carnitine to make sure that there is no secondary carnitine deficiency, and plasma amino acids, where you will be looking at glycine, methionine, glutamine. We'll talk about this in a second. And I tend to also add total plasma homocysteine, just to make sure that we're not missing combined homocystinuria / methylmalonic aciduria cases. So in just one go, you can really cover that entire biochemical map and come up with a reasonable guess as what you might be dealing with. I mentioned 3 amino acids, which I find most helpful when I look at the plasma amino acids in propionic acidemia. Number 1 is glycine. It's often elevated. If you remember, historically, these conditions, MMA and PA, were identified as ketotic hyperglycemias because they were identified based on the elevations of glycine in the presence of ketosis, so ketolactic acidosis. Methionine is also very helpful because in combined homocystinuria, methylmalonic acidemia, aciduria, you will see high plasma homocysteine, low methionine, and glutamine. Now, paradoxically, unlike urea cycle disorders, which and where you will see high ammonia accompanied by high glutamine, here you tend to see it the other way around. High ammonia with low glutamine. And low glutamine tends to be associated with more severe course and frequently seen in the context of metabolic decompensations. If I remember it correctly, Dr. Longo had published a really nice paper documenting glutamine and many others, of course, documented low glutamine in the context of propionic acidemia. Now, there are many different scenarios and possible explanations for why glutamine can be low. My personal hypothesis is that glutamine is a source of ammonia, and ammonia is playing a role of acid proton buffer and facilitates this secretion under conditions of metabolic acidosis. But that's just a hypothesis. Most likely that glutaminolysis happens in the kidney if this hypothesis is correct. Now, the nature of elevation of glycine is a little bit complicated, and it's very possible, as Dr. Pam had here at NIH and Dr. Vendidi's lab showed, that propionylation of the glycine degradation complex inhibits it, and that's what leads to the formation of excess glycine. But I think it's probably just one of the factors in the equation, although it's probably the biggest one. All right, and I already talked about the molecular confirmation using PCCA, PCCB sequencing. Now, in our experience, if your sequencing is negative, then you probably want to do a copy number analysis, or if you use panels which use sequencing with good depth coverage, then it's probably going to come together, copy number analysis and sequencing. Metabolic studies. So when you order a plasma acylcarnitine profile, you will be looking for an isolated peak of C3. On the urine organic acid, you will be looking for 3-hydroxypropionate, 2-methyl citrate with some other compounds that are listed here. Make sure that methylmalonic acid is absent. And on the plasma amino acid, we already talked about elevated glycine, low glutamine, and tends to be normal methionine under these conditions. So if you see low methionine, please ask yourself the question whether this could be a combined from homocystinuria, methylmalonic acidemia syndrome, and in that context, having total plasma homocysteine would be very helpful. Some pitfalls, and I've seen a number of them dealing with our cohort of PA patients at NIH. Mild forms of PA, for example, an Amish genotype, PCCB-related propionic acidemia, is not always identified by the newborn screen in the US, and even may have an unrevealing urinary organic acid. So you really need to maintain very high index of suspicion in order to not to miss this condition. Methylmalonic acidemia is always, right, will be present there if you in the differential if you see elevated C3. But make sure that you keep your mind open to multiple possibilities because there's so many different methylmalonic acidemias, including actually what probably is going to be one of the more common forms as we continue to study is CD320 deficiency due to high prevalence of one particular allele in the general population in North America. Maternal B12, kind of talked already a little bit about this. Multiple carboxylated deficiency. We had one test question at the very beginning. I'm not going to dwell on this. Carbonic anhydrase 5A deficiency. You should think of this when you see abnormal urine organics, which kind of suggests there could be an organic acidemia, but acylcarnitine profile is normal, or at least it's non-specific. So when you see that, you'll need to think about carbonic anhydrase 5A deficiency. And of course, primary mitochondrial disorders is always in differential. And that's in part because many organic acidemias will produce significant secondary mitochondrial dysfunction. And in fact, hyperammonemia is probably you can consider that as a form of secondary dysfunction of the urea cycle because the proximal part of it resides in mitochondria. So the diagnosis of this condition can be challenging without newborn screen, and in part because the presentation can be very nonspecific. So the neonatal crisis, hyperammonemia, severe metabolic acidosis, ketonuria, unless these tests are done, it will look just like sepsis and septicemia. So that's a little bit that's what makes it so challenging to identify them without physicians and healthcare providers thinking about this condition specifically. If this is a less severe form of propionic acidemia, you can see them present later in life with failure to thrive, recurrent vomiting, GI distress, acute and chronic encephalopathy, immunodeficiency, Rayleigh syndrome. Before we had the newborn screen, and again, this is what we're seeing through our natural history studies of propionic and methylmalonic acidemia. Without the newborn screen, many of these patients may present with a sudden onset movement disorder, such as dystonia. That's because of the basal ganglia strokes that they may experience. And it tends to be actually interesting enough if in patients who what I would consider have milder genotypes. And that's because they're not either not picked up on the newborn screen and then present with a stroke later, or before we had the newborn screen, I guess, their presentation was not severe enough to trigger metabolic workup. And, when they go back home or present later, they may present with a movement disorder because they did not receive the diagnosis in time. And the cardiomyopathy and sudden death, unfortunately, it's definitely an emerging phenotype in propionic acidemia that we had seen here in our natural history study. So if you see a patient with the cardiomyopathy and your diagnostic workup is negative, please consider doing organic acids. You can pick it up that way. So, what if you don't have access to any of these biochemical tests? There are certain things that you can still use to in sick newborn with pending newborn screen, anion gap with metabolic acidosis, lactic acidosis, hyperammonemia, elevated plasma and urinary ketones, low in normal blood glucose, neutropenia, anemia, thrombocytopenia. These are all non-specific findings, can be seen in a large number of conditions. But when you see this pattern, please think of organic acidemia. One of the more common questions that we deal with is what to do with patients who present with severe hyperammonemia. And when to start the dialysis. And I would say the general approach to dialysis is probably going to be the same as if you were dealing with the primary urea cycle disorder. So in terms of the thresholds, when you start or even contact your renal team, when you notify your NICU or PICU, when you start hemodialysis, it's going to be very similar. The question is what to do with scavengers. That's a difficult question to answer, I would say. I think most people will try to and will probably use sodium benzoate and sodium phenylbutyrate even in this context before attempting a hemodialysis. I think that makes sense. Thankfully, now we have carglumic acid that has been approved for acute hyperammonemia in this setting. I think it's very reasonable to try it. And of course, before you even think about all of these, heavy duty interventions, you will be doing protein restriction and glucose IV to maximize anabolism. You will provide carnitine. If you have to push it to like anything above 100 milligrams per kilogram per day, you probably need to give it IV because there's only so much that can be absorbed from the gut. And you will be monitoring laboratory parameters that I'm listing here: acidase, ammonia, electrolyte levels. So many of you ask questions about why why we hesitate to use nitrogen scavenging compounds such as sodium benzoate, phenylacetate, phenylbutyrate. And the reason for that is because these are actually organic acids, which will more often than not will end up in the mitochondrial matrix, and which can contribute to further acidification of the mitochondrial matrix and the mitochondrial dysfunction. But I think in reality, I think I would not hesitate to try them before we start anyone on hemodialysis. The good news about organic acidemias is that although hyperammonemia can be so severe, it can be as high like several thousands micromole per liter. It can be really severe. Interestingly enough, for most patients, it's just a one-time episode. I'm not saying that it doesn't happen, it cannot happen, but unlike urea cycle disorder patients who will be coming with hyperammonemia, very high hyperammonemia, many times during their during lifetime, very high elevations of ammonia in organic acidemia tends to be just their initial presentation, which is good. What I think is less known what to do with low levels of hyperammonemia, because many patients will be coming with levels like, if you just do routine ammonia levels, you'll be seeing levels like 7 micromole per liter, 70, or 80, or 90, or 100, 110. And but if you look at the clinical presentation, these patients may not have symptoms which are different from their baseline. So it's such a difficult sometimes clinical scenario, and not without easy ways to to address it. So we can talk about that later. So if you have questions, please save those questions until the end of this presentation. Well, thankfully, most of our patients spent their time at home. When these disorders were first described, many patients really stayed at hospital for months, if not years. I've seen cases like that. Thankfully, I think we as a medical community have gotten more comfortable managing, keeping patients out of the hospital. There are those questions that we have to deal with, for example, how to monitor them at home. What to do with their diet. Is it okay to use paracetamol and ibuprofen? And I would say that the answer to these questions is I don't find in-home detection using keto sticks or urine ketones very useful to predict who may or may not be admitted to the hospital. So I do not prescribe them to my family and do not advise them to rely on them. The diet modification, I think this is so specific, and it depends on the approaches for each individual team at every hospital, and we can talk about this a little bit later. And then I think it is appropriate to use paracetamol and ibuprofen in these conditions. Although I would say if you have to use ibuprofen, please beware of the chronic kidney disease. I would be much more conservative with that class of drugs in anyone who has low renal, who has kidney dysfunction. Some controversial topics. Many patients, and I would say probably a quarter to maybe 20% of patients that we had seen here, and we've seen about 20, maybe 52, 53 now patients here at NIH with PA. About a quarter to maybe 20% of them receive some form of gut flora suppression, usually metronidazole. At this point, it's still not clear to me whether it makes any difference or not. The use of probiotics, that's another very common question we hear from parents affected by PA. I would advise you to really look at if they use some kind of commercially available probiotics, please take a look at what exactly is present there and whether that particular strain of bifidobacterium or lactobacterium, whether they are propionate producers. Some of those some of the bacteria that we have seen are actually natural propionate fermenters. So, may not actually work in a patient's favor if they use it. Biotin supplementation, a very common situation. Actually, very large doses sometimes. And when theoretically, it is possible that some patients can be biotin responsive, but I had not seen them in practice, personally. And I think there are some clinical scenarios where you can conceive of biotin being actually interfering with your monitoring of their labs. For example, we know that biotin supplementation can interfere with lab tests which use biotinylation and antibodies against the biotin, which is part of the assay. And specifically TSH and PTH, it can actually be affected by biotin supplementation. So if you have concerns about these hypothyroidism or chronic kidney disease, these hormones can be affected frequently. If that is the case, you can discontinue biotin for maybe several days, a week or so. Run the test, and then family wants to go back on biotin, they can proceed. We already talked about levocarnitine. We see ranges from anywhere between 50 and 200 milligrams, sometimes even higher. And 200 milligrams per kg per day can be problematic for adults with a large body weight. So, and I think at least our research suggests that 100 milligrams per kg per day is probably on average the maximum, but they can be absorbed from gut, but it varies significantly from patient to patient. So please consider that as a factor that anything above 100 milligrams per kg per day for many patients will probably turn liver carnitine into a laxative, which some patients actually may benefit from in this condition because of the suppression of the gut flora. Many patients will develop prolonged QTC intervals, and some of the anti-emetics which are effective can actually can have a black box on them because they can prolong QT interval. So, and let me just skip a couple of other things here in the interest of time. Dietary management. So probably if there's one thing that makes a big difference in the life of our patients is for severe forms of propionic acidemia, is the presence of G-tube. Many patients and families can be a little resistant initially, so I'm sure you've dealt with those scenarios many times. But I would introduce the idea of placing a G-tube as early as possible. We also keep here through the natural history study of patients with PA at NIH. We do very careful calculations of protein intake. And one of the big things that we see here is that there are many patients who are managed without any medical foods at all. I would say maybe a third of the patients. And interestingly enough, it doesn't seem to depend on whether the patients are severe or not. We've seen patients who are very severe who are managed without medical foods, meaning the incomplete protein. And we've seen very mild patients who are managed with a lot of medical foods. I think over time we noticed that, especially with the release of guidelines and recommendations for how to manage and design protein prescriptions, we noticed the convergence. We don't see a lot of sort of significant outliers one way or the other on either end of the spectrum. But I would say that we rarely see these days like a 50-50 ratio of complete to incomplete, 50% to 50% complete, incomplete foods. More often than not, we're seeing something like 70% complete, 30% incomplete protein, and then we definitely noticed in the last several years is that the protein intake will more often than not adhere to the recommended daily allowance. In other words, we used to see like 2.5 grams per kg per day. Even in older patients with severe form of PA, we don't see that anymore. So we tend to see 0.91 gram per kg per day in older patients. So if you have any questions, we're very happy to engage you and talk to you about your specific circumstances. But keep in mind, these are sort of big topics that I think a lot of us spend a lot of time thinking about them, and we're happy to walk with you through your recipes and discuss them. All right. Another common question that I hear and I deal with is, so how do we monitor PA patients? And I think this is one of those harder things because I cannot think of any specific biomarker that can actually help you figure out, okay, do I need to adjust my protein intake? Do I need to go up? Do I need to go down? When do I bring the patient back because they're at risk for decompensation? So I have not noticed at this point, I don't even see specific biomarkers that we can use to stratify our patients. But what I find very helpful is to use genotype. And if you see patients with 2 loss of function alleles in PCCA, PCCB, then you should consider them as very severe and talk to them about G-tube, even introduce a concept of liver transplantation if you see this patient comes in and out of the hospital frequently. You can use C3 and plasma 2-methyl citrate and even GDF-15, which is available through some CLIA labs in the US. But I find that usually risk stratification is probably most relevant in the first several years of life, right? When you're trying to figure out what would be your strategy to manage patients. And I noticed that C3, 2-methyl citrate, and GDF-15 are not as useful to stratify them in the first 2 or 3 years of life. When they turn 5 and 10 years of age, I think C3 and 2-methyl citrate and GDF-15 are much more in line with the severity of their condition. But, that's much later when I feel like clinically we already know what we're dealing with. Some routine labs that I would recommend doing is doing plasma amino acids. They do help you to figure out if your patient needs a little more protein than they are receiving or they're receiving too much. The only thing I would recommend is when you do that, do it 2 hours up to the last feed. Too many times, I think we're just chasing our own tail. If the the labs or plasma amino acid sample is collected at the time while the patient is being fed. And unfortunately, under those conditions, plasma amino acids will be reflecting what's coming from the gut and not what's actually is there at the baseline. If your patient turned 15 or is in the third decade of life, 20 years and older, young adult, please check their vitamin vitamin D, TSH with reflex 3T4. Don't forget about triglyceridemia. I've seen some of the most phenomenal numbers for hypertriglyceridemia at NIH here in patients in the third decade of life. And so it needs to be managed because it's a risk factor for chronic and acute pancreatitis. And pro-BNP. So if echo is not available or patient is not able to schedule their echocardiogram yet, you can, but your patient happens to be in your clinic, and you recommend tests, you can also add pro-BNP to screen for cardiomyopathy. It's a little, the increase can be delayed because it tends to reflect the dilation of the right atrium as opposed to ventricles, and sometimes that's a little bit of a delayed, later finding. You may see some decrease in the contractility before dilation of the right atrium. So pro-BNP can be helpful, but not as an early sign of cardiomyopathy. So there's some unresolved questions. You may have seen this publication coming from our European colleagues, a very astute study showing that many patients with PA and MMA have elevated alpha-fetoprotein. We can confirm that is the case here in the United States as well. What to do with those numbers is a difficult question. I had not seen yet cases of hepatocellular carcinoma, for example, in this patient. So when would I consider doing alpha-fetoprotein in practice? If you see patients with findings suggestive of fatty liver, elevated ALT, AST, if this is the third decade of life, I would probably do a baseline and then consider, if you see a significant elevation of alpha-fetoprotein, you can consider doing some imaging studies. One thing we had shown through our research is that because of the reduced muscle mass, creatine production, endogenous creatine production tends to be low. And therefore, it can artificially inflate GFR, estimated GFRs. So cystatin is much less liable to the decreased muscle mass because it's produced elsewhere. And so if you do keep track of, and I recommend that you do keep track of the renal function, order cystatin C once a year. That will give you the answer about their CKD presence or absence. A quick comment about transplantation, the common thing. So we've seen many different combinations or scenarios where liver, kidney, heart, liver transplantation had been either considered or performed in PA patients. And I believe when we sort of go back into reflect on cases that we had dealt with, when did we recommend or supported the decision to undergo liver transplantation or any of these forms of transplantation? Transplantation is when you see frequent and severe metabolic instability, severe chronic kidney disease, when you pretty much have no other chance, no other option really, but just to offer either dialysis or kidney transplantation, and then severe cardiomyopathy with fibrotic changes. And that would be the indication for the heart. I know that we as a community are wrestling with the question whether severe cardiomyopathy should warrant liver transplantation, and I know that it's been, there are differing opinions on it, but yes, we had seen patients whose cardiomyopathy improved after liver transplant, but we had also seen patients when it returned at some point after the liver transplant as well. All right. So again, lots of things we can talk about the liver transplant or solid organ transplantation in general, but the risk-benefit ratio is absolutely unique to every single patient, and we had not seen scenarios which are alike here. So what usually tends to affect our decisions is the severity of propionic acidemia, how frequently they get admitted for decompensations, the presence of chronic kidney disease, presence of cardiomyopathy will help you determine if it's just simple liver or liver kidney or other types of combinations. And then remember that 18 years of age in the United States, at least, is a watershed moment where the MEL scores can be calculated differently. So I think, before your patient approaches age 18 years, I think it's worth having a discussion if this thought crossed your mind that this patient might be candidate for a transplantation. One thing I also wanted to, sort of put it out there for our community to discuss is whether diet should be altered after the transplant. Our group is of the opinion is that the protein restriction after transplantation should stay in place. And that's in part because liver transplantation does not protect the brain. And these patients can still be at risk for basal ganglia injury, and therefore we do not recommend relaxation of the diet. One thing that I would also want to appeal to you is that as we look at the age distribution, the NIH cohort, is that we see that 50% of our patients are now adults, and there's a significant shortage of internal medicine trained geneticists in anywhere in the world. So there's definitely a great need. So if there are people who are being trained right now in your internal medicine grad, so I'm very grateful that you chose the field of genetics because there's such a big need for your help in our world. All right, so I'm going to move on to isovaleric acidemia. From here on, it's going to go a little faster because propionic acidemia is just such a complicated disorder, and we have lots of things to talk about. Isovaleric acidemia is in many ways very similar to other severe forms of organic acidemias, with an element that some of these conditions, some of these patients can be on the milder spectrum. We'll talk about this. So the way to pick it up clinically is, interesting enough, this condition does have its peculiar order. And some people describe it in very different ways, that dirty socks or there are other descriptors that I've seen in the literature. Let me just keep this descriptor for now here. So it usually happens at the time of if a patient is acutely sick. So you may not see it in patients who are in metabolic homeostasis or who are doing clinically well, or if they're affected by a milder form of this condition. And so this is the result of the hydroxy isovaleric acid and accumulated in the body tissues and being excreted through unconjugated isovaleric acid that is responsible for this order. Now, you've seen that the act sheets and the algorithms have been updated. So I like to go back to this older version because it kind of brings it down and sort of it's a little more elaborate. But if you feel overwhelmed, I think the updated act sheets, this particular updated act sheet is pretty good. It tells you what you need to do on the spot in the specific second tier testing. Urine organic acyl-carnitine profile in plasma and urine acylglycine can be very helpful to differentiate these conditions. And all of these tests typically lead to molecular genetic testing. Now, some practices in North America may choose not to pursue molecular testing, especially if the genotype had been established before in another affected sibling. But I personally tend to pursue molecular genetic testing confirmation in all patients, especially if it's a first case identified in the family. So we talked a little bit about the diagnostic approach and the diagnostic workup of these patients. So urine organic acid will show you multiple metabolites, including presence of isovaleric glycine and 3 as you see it listed here. Acyl-carnitine profile will see the presence of elevated C5, isovaleric carnitine. And one of the other reasons why I do advocate the use of molecular genetic analysis is that there are some genotypes which tend to be associated with a milder biochemical and clinical course. And I think that can help stratify your patients and determine your management strategy in an early age. Now, I realize that the genotypes, it tends to be very heterogeneous, but I think it is especially in some with some people groups, you will see that it can be quite helpful. I rarely use residual and measurement of the residual enzyme activities in fibroblasts and lymphocytes, but in some, I guess, difficult questions when you need to have an orthogonal method to confirm your suspicion, you might default to that option. Now, if patients are not identified or not picked up on the newborn screen, they may present with neonatal crisis and acidosis and hyperammonemia. And I've seen patients and there's which presented like this, and they can be very severe. Thankfully, a lot of patients do not present with a metabolically severe picture, and they can be metabolically milder and have intermediate course. And then depending on what you see, a bit depending on their presentation, this is a little bit of a judgment call. You can decide whether you want to use protein restriction in these patients and the amount of carnitine that you prescribe, and whether they need to have glycine supplementation. And glycine supplementation is really there to facilitate the excretion of excess metabolites through glycine conjugation, because one of the compounds that is you find in the urine is isovalyryl glycine. So you can provide glycine in that form. So protein restriction, carnitine, glycine tend to be, restricted to the metabolically severe group of patients. Patients who are milder or have intermediate forms may get away with just carnitine supplementation. Now, you will probably need to follow them very closely, establish good therapeutic relationships with the family, provide them with the emergency room letter in the first several months of life until you figure out what the baseline is and what the trajectory is. If the genotype is not known, or even if it's not known, if it's known, but you don't know, if it's a unique heterogeneous combination, then you will have to default to your clinical judgment. A common problem, I think, right, for many of us is whether we should use leucine, the precursor for this condition, leucine-free amino acid formulas. And so this is just an example of another controversies in our field. This is probably a 5-year-old paper, which showed that some patients are receiving formula and some patients are not. And there's a big difference in the dietary practices. And I don't think we are at the stage where we can reach the consensus of, to determine who needs to be on this formula from the outset and who may not need it. 3-MCC deficiency, another condition that you pick up on the newborn screen. If you remember the test question at the very beginning, this is a very common condition, one of the more common conditions you will be dealing if you have a universal newborn screen program. Here it's also it's derived from methylcredinyl coenzyme A is derived from leucine, and this particular enzyme, being carboxylase, is biotin dependent. So we'll talk about this in the next several slides. You can identify based on the presence of C5OH on the acylcarnitine profile in the newborn screen, but what you will be looking for on the urine organic acid when you order second-tier test is the presence of 3-methylcredinyl glycine. So again, this is one of those compounds that undergoes a very quick conjugation with glycine in our body, in the liver specifically, and that's why you may see a peak which is rather pathognomonic. An isolated peak is rather pathognomonic for this condition. Here's the old style ACT sheet if you prefer that one. This is the new style ACT sheet. As you can see, in many conditions, you will end up doing molecular genetic testing. 3-MCC is probably one of those that I'm not sure I would pursue it, but I've done it before, and I feel like it's not a very helpful test unless you have a diagnostic dilemma. You're not sure if it's a 3-MCC deficiency. So again, you can just probably fall back onto doing urine organic acid, plasma acylcarnitine profile, and I would definitely do plasma amino acids under these conditions, because there's quite a few things on the newborn and this that may present with elevated C5 that you may find plasma amino acids helpful. Now, C5 is probably one of the more common elevations that you will see on the newborn screen, but based on the prevalence of this condition, I would say this is probably the most likely and the most common explanation. We covered a lot of these things, in the, when I explained and presented this condition. I just wanted to maybe highlight one thing, is that sometimes you may deal with not the 3-MCC deficiency in the infant when you identify them on the newborn screen, but in the mother. And sometimes you can also identify secondary carnitine deficiency in the infant, which can be a consequence of 3-MCC deficiency in the mother. So it may present with elevated C5OH, and it may present with secondary carnitine deficiency. So just keep that in mind. Now, the outcomes and management. I think, so before we had the newborn screen, I think it was a relatively, well, it was a less common diagnosis to be made in a biochemical clinic or metabolic clinic. What I think we had discovered with the introduction of the new universal newborn screen is that the rapid expansion of the number of infants that we pick up. And what we noticed at that time is that many of these patients who were picked up on the newborn screen did not have a lot of manifestations. They tend to be metabolically stable. They had relatively normal developmental outcomes. So there had been several efforts to document outcomes with the introduction of the newborn screen. As you can see, one of them is comes from mostly European colleagues. So another paper comes from mostly US colleagues. As you can see here, the number of reports of neurologic abnormalities, metabolic symptoms is concerning, but the significance is unclear in the retrospective sample. So most of the studies have been retrospective. So at this point, we're not 100% sure whether this is a primarily biochemical trait or it's a biochemical trait with some patients who will present with manifestations. So I, in practice, tended to be on the conservative side, even though I would not manage them with any, let's say, protein restriction. I would probably continue with some carnitine supplementation and routine follow-ups. But I realize there will be a range of opinions, and this is not the only way to manage these patients. This is another very nice paper that came out of out of California. Given their big number of a very large number of infants screened, they can identify a significant number of these patients, and given the sort of unified system of registering these patients, I guess it was easier for them to keep track of outcomes. And what they noticed is that again, a wide range of practices. A small but still a significant number of cases where they did see some symptoms like hypertrophy and irritability. So, but thankfully, the majority of these patients are completely normal. So again, you will have, I guess you would have to default to your own personal style and the practice that your group adopted and how you want to manage these patients. But thankfully, a lot of these patients tend to be on the milder end. Multiple carboxylase deficiency, and this is the last group of conditions that we'll discuss today. So biotin cycle. One thing I wanted to point out is the biotinidase and holocarboxylase synthetase do two different things. Holocarboxylase synthetase attaches the biotin to apocarboxylases. And therefore, in practice, what you will see is that if the nature of the enzymatic defect and mutations is such that it impairs the synthesis but can be overcome by providing extra biotin, you tend to provide more biotin compared to biotinidase. Because in biotinidase, it lyses, it separates biotin from through proteolytic from biocytine, and therefore even if this enzyme is not working, or if its enzymatic activity is almost zero, because you're still able to provide free biotin, you can still resynthesize apocarboxylase. You just have to continue to provide that free biotin. And therefore, you tend to see that even in severe forms of biotinidase deficiency, if you provide sufficient amount of biotin, biotin, you can see complete clinical response, as opposed to whole carboxylase synthetase, where it has to synthesize. Even if you provide enough biotin, it may not be able to do its job. So you tend to have use higher doses of biotin, and you may not necessarily see a complete response to that supplementation. There are many carboxylases in our body. Actually, I shouldn't say many. There are 4 carboxylases in humans. Actually, there are more carboxylases in nature, but in humans, 4 of them are listed here. And you can see they operate in different parts of the biochemical map, which is why on the newborn screen, you can see them on the acylcarnitine profile by identifying different peaks, C5-1, C5-OH, C3, and so on. But in practice, the biotinidase deficiency is picked up through the enzymatic assay on the newborn screen in most places that I'm aware of. But biotinidase deficient or biotinidase assay in the newborn screen is not going to help you to identify full carboxylase synthetase. Okay, I hope I did not make it more complicated than necessary than needed. Biotinidase deficiency, we'll start with that one, is one of the more common conditions you will be dealing with, and probably one of the most rewarding disorders to deal with, because the newborn screen works really well. The treatment is straightforward, one dose of biotin a day in the form of a tablet, and it results in a nearly complete response to treatment. Without treatment, and I think probably under most circumstances, we're not going to it's not likely to see that kind of scenario. But let's say if you were dealing with a migrant family where newborn screen was not available at the time when the infant was born, you can still see situations where it's missed. When the treatment is not instituted in time, there are multiple complications. As you can see, there's a significant overlap with the other forms of organic acidemias, but probably what we tend to see in this condition is the presence of alopecia, eczematous rash that is resistant to treatment, hearing loss, vision loss, ketolactic acidosis, and then acylcarnitine profile, as we talked about in urine organic acids, will show you multiple peaks, because of the nature of carboxylators. I'm gonna skip that slide and talk about the outcomes. I think, a very nice thing and a very rewarding experience of dealing with biotinidase deficiency is that it nicely responds to treatment, even in patients with profound deficiency. Most patients that we identify, because of the presence of common allele in the North American population, will have partial deficiency, but profound deficiency is seen probably in 15% of cases. So even in patients who have profound deficiency, if you start a treatment and the patient is compliant and they give appropriate dose, they will have a nearly complete response to it. This is another paper that comes from our European colleagues in Italy, also showing very similar experiences that they have. See a full prevention of clinical symptoms with no adverse effect. Cholecarboxylase synthetase deficiency has very similar spectrum of manifestations, but they tend to be on the more severe end. And then you need to use a much larger doses of biotin, but also consider a scenario where you may not see complete response to biotin supplementation. If you see partial response or underdosing, or a situation when the patient's underdosed with the biotin, you can see these symptoms, which present with chronic encephalopathy, alopecia rash, and episodes of recurrent acidosis. And there's one more thing that I wanted to add to your list of things, even though this is really not an organic acidemia, but there's another condition that can respond to biotin supplementation. It's biotin-responsive basal ganglia disease. This is a result of biallelic pathogenic variants in SLC19A3. It's a thiamine biotin transporter, so it tends to respond to treatment with biotin with and without thiamine. Probably in practice, most of us will use both the combination of biotin and thiamine. So if these patients are treated early, they tend to have no neurological sequelae. But symptoms can return if the treatment is stopped. All right. And the dose of biotin varies. Most patients with biotin deficiency will need to be on 5 to 10 milligrams a day. I think it's very well tolerated. With whole carboxylase synthase deficiency, 10 to 20. Some patients I've seen go up to 40. I've seen, patients who need to get as much as 100 milligrams per day. I guess it's a little hard to judge, right? Where the upper limit is for that condition. But again, 40 is probably the highest that I've seen in person. And none of these patients require protein intake restriction if they are receiving biotin. And the prognosis, thankfully, is excellent if the treatment is started in time. And with that, I'm gonna stop here and see if there are any questions.
Thank you, Dr. Shchelochkov. That was great. Any questions for Dr. Shchelochkov? Oh, there's one in the
Yeah,
chat.
so I see a question. Does partial biotin deficiency need to be treated? I would treat it. Any other questions?
Do you know, in that 25-year follow-up study from Dr. Wolf in Michigan, did they have untreated partials?
I think just in general, his approach was to provide supplement everyone. I need to go back and actually and double check. I hadn't read it in a while.
I mean, I'm thinking of people who just got lost to follow-up and stopped treatment by themselves.
Yeah, that's a good question. And if anybody else knows the answer to that question, please feel free
I,
to.
I thought I remembered hearing him say at one point, not him directly, but hearing from him that partial, even untreated, never have symptoms. And it was anecdotal, I think. I don't think it was published, but I don't know. I might be wrong.
Yeah, I would not risk the treatment with biotin. It's just so ubiquitous and has such a positive, I would say, or favorable side effect profile that I feel like I would not hesitate to recommend treating partials with 5 milligrams of biotin. Yeah. Brian, I saw you just popped up on my screen. I don't know if you had a comment or a question. I see there's another question in the chat. Could you expand on the sudden death findings in your natural history study? Yeah. Um, we had recently we saw a patient, it was a telehealth visit, who was a teenager, was doing weightlifting. Apparently was using something like an energy drink that I was able to find it on Amazon.com and kind of look it up, and just see what is there. Obviously, there was a lot of, well, I shouldn't say obviously, but that particular drink contained a lot of caffeine and maybe a ephedra. And I think that's a little bit of a question mark whether it contained something like that or not. And so during one of the exercise sessions, developed, went, just dropped dead and was resuscitated, was taken to the hospital. So doctors, did their workup, suspected that found evidence of dilated cardiomyopathy. One thing led to another. It was eventually confirmed to have the diagnosis of propionic acidemia. Yeah. Unfortunately, I had not seen this after we saw them initially during COVID-19 over telehealth. I had not seen him for follow-up, but I'm just a little afraid that I think some cases of dilated cardiomyopathy that we miss can be due to propionic acidemia. More often than not, when we do confirmatory testing, at least one of those alleles tends to be Amish. So again, I'm afraid that we could be missing some cases of propionic acidemia that may present later with dilated cardiomyopathy. But now you could say, how often does that happen? Well, that's a hard one. That's a difficult question to answer, but that's 1 out of 50 for us. So like 2% of PA patients, and no, that's the representation. Yeah, the follow-up question. So here we're not in a metabolic crisis. No, no metabolic crisis at all. In fact, if you actually look at, since I mentioned the Amish allele in PCCB, interestingly enough, most Amish patients will never develop metabolic acidosis. I'm not saying that they cannot. I think it does happen. It just tends to be a very uncommon situation. So they may, and I think that's the danger with them, is that they tend to not feel the effects of high protein foods, and they may develop cardiomyopathy later. And I think there had been anecdotal sort of evidence that some Amish patients who did develop cardiomyopathy due to PA as young adults, Holmes Morton was, and Kevin Strauss sort of conveying this anecdote of an Amish person working in the field dropping dead, and speculating, right? Could that be as a result of dilated cardiomyopathy and ventricular arrhythmia? We don't know for sure, but in this particular situation, the patient that I described, who had no family history, doesn't have any other reasons to believe he had propionic acidemia developed it. Yeah. Long QT, yes. Long QT, yes. It's very common. I would say probably a third of our patients develop long QT with propionic acidemia. And by the way, it is present in methylmalonic acidemia as well. It's just not as severe, and prevalence is probably a little bit lower. So this long QT interval is a feature of organic acidemia. Katie Anderson, as a genetics fellow, I had a PA patient who died of an arrhythmia while in the ICU on monitor. So it was out of nowhere VTAC. Thank you. Yeah. So I think it's definitely a thing. One of the presentations of clinical phenomena. Certainly worth pursuing. This is okay. Newborns with a positive screen for profound partial biotinidase deficiency. Do you repeat the biotinidase activity measurement at 6 months or at what age? I think it really depends on your specific approach. I would say that if you pick them up on the newborn screen and you do molecular testing, I don't do anything else at 6 months at all. Would I repeat if I did once and they had the classic newborn screen findings? Would I repeat the enzyme activity at 6 months? I'm not sure I would. But other people may actually might be missing the rationale. What would be the point? Yeah, I would. I just tend to believe, the outcomes of the biotin and liver immaturity. Oh, interesting. Liver immaturity presenting as partial biotinidase deficiency. I don't know.
But you're checking red blood cell activity, right?
Yeah, I'm not sure. I'm not sure I would. Again, it probably varies by practice. Like I know that some people would not even do molecular testing, confirmatory testing. I did, uh, but not everyone would. Well, it's 3:23. Are there any other questions? It looks like we still have some extra time. Okay, well, hearing none.
All right. Well, thank you so much, Oleg, for presenting. It was a great, clear presentation with great
So
pearls.
much.
Everybody have a great weekend, and we'll see you next week. Again, remember, it's an hour later. Thank you. Bye, guys.
Thank you so much. Bye.